doesn't save to your computer. It's all anonymous. So if you go to menti.com, it's menti.com, it'll pop up a box that will ask you for an access code. And you enter that access code into, and I think we have it, is it on the next slide? The code for today. There we go. So you'll enter the code 1205255. And we'll go ahead and put that in the chat box for you too. And that'll allow you to participate in the polling today. Our polling is done in real time. And if you don't want to download do it through the Menta app, you can also put your answers into the chat box. So let's go to the next slide. So as we get started, part of our welcome is the establishment of our house rules. So this is our internal comfort agreement. We have a lot of folks joining from different parts of the state, from different perspectives and experiences, and our goal is to create a safe and inclusive space for conversation and discussion and for learning. And as part of that, we've established this set of rules. And so for those of you joining us on the phone and are unable to see the screen, the house rules are to be kind and courteous, to listen attentively and with an open mind, speak honestly, share the space, learning leaves but names stay, step up, step back, and reserve the right to change your mind. And also, just as a note, this webinar is recorded. We will have the link to this along with our previous town halls available on our website after the conclusion of this event. So let's go to the next slide. So our first poll is, this is just for us to get an idea of where everyone is joining from, if you could enter in your county. And the code is, again, it's at the top of the screen. So it's 1205255. So Southern California representation. Give everybody another moment if they want to enter anything in. And again, if you'd like, you can also enter your responses into the chat. We've got someone from Michigan again. Welcome. Let's go to the next screen. This one here is to help us know who's in the room just from your perspective and experience. So family member, parent, caregiver, peer, consumer, if you're one of our affiliates, if you're with a provider, you can go ahead and check all that apply. I know that we all kind of wear multiple hats too. All right. Well, thank you all for those responses. Go to the next slide. All right. So I am going to introduce to you Jessica Cruz. She's the CEO of NAMI California, to provide a welcome for you all today.
Thanks, Angela. And thank you everybody for being here. I know that there's a lot happening across our state, and so we so appreciate you taking the time to join us for this town hall. I'm super excited about our presenter because she's a part of the NAMI family. She came from the ACLU. She is an organizer. She's a fierce advocate. Many of you know her from working with her about 5 years ago, when she worked at NAMI California as our legislative and policy director. From there, we couldn't keep her because she's just so amazing, and she went to CPEHN to really kind of to move with her passion, which is about racial and ethnic disparities and health. But she actually took her passion for mental health with her and has been a driving force over at CPEHN around this issue and the other issues that CPEHN focuses on. And she's the executive director over at CPEHN and has been doing an amazing job in all of her leadership roles there. And we're so happy to have her here partnering with us to share a lot more about racial disparities in mental health and in our community, and how we can advocate and help in the work that they're doing to move this issue forward. So please help me welcome Kieran from CPEHN.
Thanks, Jessica. It's a pleasure to be here with all of you. It's always a pleasure to be back with NAMI, one of my favorite places. So thank you for that warm welcome and the invitation and all of your time today. Like Jessica said, I'm with the California Pan-Ethnic Health Network, and I'm just going to check with Angela here. Are you advancing the slides? Can I just say advance slide?
Yep.
Sorry, we didn't program that part. Okay.
Absolutely.
So if we could go to the next slide, please, that would be great. So just to tell you a little bit about, I know Jessica told you a little bit about who I am, but to talk a little bit about who CPEHN is. So we are a multicultural health policy organization, advocacy organization here in California. And what that really means is that we work very closely with communities of color across the state of California to really mobilize, unify, bring our voices together, and uplift the needs of our communities around health equity and eliminating health disparities broadly, certainly including mental health. And it's been, I think, it's been quite a year for all of us, right? A very difficult time that we're all living through. And I think for CPEHN, as we've kind of reflected on the last 9 months now of 2020, I think we see a lot of things that are sort of coming up and getting attention that are things that our communities have been struggling with for a long time. And so just for a little bit of history, we were actually founded in 1992 in the wake of the police beating of Rodney King in Los Angeles and the subsequent community outcry and civil unrest there over the resolution or lack of resolution of that incident. And so our founders came together at that time and said, it is clear that we have really deep-seated problems around racial equity and racial justice in this state, not to mention in this country, and that we as different communities of color need to come together, need to figure out how we can support each other, how we can stand in solidarity, and particularly how we can focus on healthcare and the health of our communities. So I think as we've sort of been living through 2020, really feel like we are called back to that history again and thinking about what that means and the role that we play in the community. And next slide, please. So this is a little bit about how we do our work. This is our theory of change, if you want to be technical about it, but this is sort of like how we make the change we want to see. And broadly, really, our goal is to ensure that health justice and equity are on the agendas of policymakers and that communities and community voices are part of the policy making process. And so we use several different strategies to get to that goal. First, we build people power, and so we work really closely with dozens of community organizations across the state to come together to speak, whether it's in Sacramento, whether it's at the county level, together sort of with one voice about the changes we want to see. We pass, change, and implement policies. So I mentioned we are an advocacy organization. You know, we are now virtually, but generally in the state capitol, right? Every day when they're in session, we sponsor legislation, we work with departments and agencies, and more we work also with local counties and sometimes city governments as well. We invest in communities of color, and this one is really important to us because I think, you know, we all know there's been generations of underinvestment in communities of color broadly. And so we feel like one of our responsibilities as an organization, one, is to drive resources to communities, whether it's through state programs, making sure that we are investing in young people, in economic development, all those things, but also that we as an organization often take a role of sort of fundraising for organizations who are smaller than us and have difficulty accessing resources and that kind of thing, and really making sure that we are putting dollars into communities where they can be most impactful. We also connect data, stories, and partners. So we really play sort of a convener role in the field around bringing people together, but also making the connections for policymakers and for communities on different issues. And all of this, again, sort of in service of creating equitable conditions that promote health equity and ultimately allow all of us to thrive and prosper in our communities. Next slide, please. So we're certainly here to talk about mental health. I want to start with a little bit of an overview, though, about how we look at health equity and health disparities broadly. So if we can go to the next slide, please. And, you know, when I think about health disparities, I often think about sort of what does this boil down to? We do at CPEHN, we're sort of guilty of doing a lot of in the weeds data sort of wonky work and talking about things in that way. But ultimately, when we think about health disparities, I think one of the most striking realities that faces us is the really serious difference in life expectancy based on race. And so we know that there's about a 10-year gap, and that when you think about, you know, a child being born today just based on their race, they already have an impact to their life expectancy, and particularly for our Black, Native American, and Latino communities, it's a negative impact to life expectancy. And so we think about what is everything that goes into creating the conditions that cause us to have that reality. Next slide, please. One of the ways that we think about this too, when we think about mental health, is that, you know, we have really serious disparities based on race, which is what we focus on. We also have disparities based on whether you are living with a mental health condition or a serious mental illness. And where those two things intersect, right, where race and mental health intersect is where we see some of the deepest disparities and where we focus a lot of our work. So this slide is a little complicated, but basically shows you that people who are living with a serious mental health condition are also more likely to be living with a physical health condition, particularly a chronic physical health condition. This slide is about diabetes. So you can sort of see what are some of the co-occurring conditions, and that some of the most likely ones are serious mental illnesses. And so again, it really focusing on where is that intersection. We don't have the data on this, but I think if you were to overlay race on this, right, and also look at that, you would see even deeper disparities. Next slide, please. This is, again, going back to sort of thinking generally about health disparities. What do they look like? So as an organization that's sort of grounded in the consumer perspective, we often think, you know, there's indicators of health that are clinical, right, that are reported, sort of, do you have diabetes, what's your blood sugar, you know, what's your blood pressure, those kinds of things. And then there's indicators of health that we ourselves report, right? And to us, those are some of the most important. And so this slide is showing you self-reported health status. So when you are asked, how do you rate your health? Is it excellent, good, fair, or poor? And so what you can see on this slide is that people of color are more likely to self-report their health status being fair or poor, right? Which is not what we want to see. We want to see the opposite. And so that also tells us that there are these disparities in health status, even leaving aside clinical outcomes, but also in how we feel our own health is. Next slide, please. And as we all know, we're living through a pandemic. This is a huge focus of CPEHN's work right now because it's impacting all of us, but it is disproportionately impacting people of color, particularly low-income people of color. And so if we can go to the next slide. So this is, if you, again, it's sort of a lot of numbers. I told you we're guilty of using a lot of data at CPEHN, but what you can see here is that compared to the share of the population, Latinos are contracting COVID at a higher rate. A lot of reasons for that. There's a lot of things you can look at in terms of who is an essential frontline worker, who's still having to go out and be exposed potentially to the virus. But ultimately, there's a very significant disparity, right, with Latinos being a little bit less than 40% of the California population, but over 55% of the COVID cases. And that really, in our view, being a place we need to focus when we think about our response to COVID-19 and how we're going to take action around the virus. And if we can go to the next slide, please. So this, again, is highlighting not necessarily who's contracting COVID, but who's dying of COVID, because we know that is not born equally either. And so you can see here, particularly the African-American and Black population dying at a much higher rate than either their share of the population or than sort of adjusted other populations. A lot of this having to do with comorbid health conditions that are a result from racism within the healthcare system. But I think COVID really putting a spotlight on this problem and something that is pretty deeply entrenched. And one of the things, and I promise I'm going to get back to mental health in a minute, but one of the things that we think about and we say a lot with COVID is, you know, the virus sort of none of us were expecting, right? This pandemic hit, it's something I didn't think I would live through, right, in my lifetime. But the response to the virus is human and state decisions. And so the fact that we have these disparities are human and state decisions. They are preventable, they are changeable, and that is really where we need to focus our work. So next slide, please. So this shows you, now as we think about COVID, and I know NAMI's done a lot of good work and conversation around this, the mental health impacts of the pandemic. So you can imagine that people who are being most impacted by the pandemic have to be most worried about contracting the virus or dying from the virus, losing their jobs or their homes because of the virus, are potentially also going to have a disproportionate mental health impact. And generally we see that living through this pandemic is impacting a lot of us and our mental health, right? But again, that also is not born equally. And so you can see, particularly for those who report that their mental health has gotten a little or a lot worse, that again, Latinos are feeling particularly impacted in terms of mental health. And it's, you know, sort of not surprising, but it's, I think, another thing we really need to focus on if we envision a world where everyone has the opportunity to thrive and prosper. And this is, I'll just mention, this is some data that California Healthcare Foundation is putting out pretty regularly through regular polling. So if you're interested in sort of following these issues, you can find a lot more about this, about how people are feeling, about some of the differences on their website as well. Next slide, please. So I think this slide sort of says it all. Disparities are driven by racism. And we like to make sure we're very explicit about this, that disparities are not driven by race, they're driven by racism. And that is a systemic and structural problem that we have in this country, in this state, that is deeply embedded in the fabric of our institutions, and that we have to have a laser focus on that. We have to be able to acknowledge it, and we have to have a laser focus on it in order to dismantle systemic racism, which is what is going to be needed to close these disparities or to eliminate these disparities. Next slide, please. So turning really specifically to mental health, CPEHN a couple years ago kind of looked at some of the data around mental health, around utilization, around outcomes, particularly looking at our Medi-Cal program, both our county side as well as our health plan side. And one of the things we observed is that there was actually very little data where you could look at who was able to get mental health care by race, by ethnicity, by language, by sexual orientation. And so even though we knew based on our community experience and our personal experiences that there are really significant inequities, the state wasn't producing any data that the community could use to talk about that. And to us, more importantly, that meant the state really wasn't looking at these issues, and neither were the counties. And so we thought it was really important that that change. And so we worked with a number of our community partners. We sponsored legislation and required the Department of Healthcare Services to start doing regular reporting around mental health access, utilization, and outcomes by race, by language, also by sexual orientation and gender identity, although that part they are not doing yet, so that's continued advocacy. So if you go to the next slide, I'll kind of show you a little bit of what we found. And I don't think this is going to surprise all of you who are very experienced advocates and I know care a lot about these issues. So here you can see the blue bars are managed care or the health plan services, and I'm only talking about Medi-Cal, right? And the red bars are the specialty or the county services. And one thing that is important to point out that I should have put a slide in for, but I didn't, is that, you know, we do have, as all of you are aware, this sort of bifurcated mental health system in Medi-Cal. And all of it is underserving most people, right? I think we can sort of stipulate to that. And we are really concerned actually about the health plan side in particular, because if you sort of think about the needs and the number of people who need those more mild to moderate services, that's a really big number. And it's not reflected, it's not coming up in the data, people are not getting those services. So just to kind of keep in mind, that's one of the reasons that we've done this breakdown of the data so you can kind of see. But broadly, what this shows us is that there are differences in mental health service utilization by race. And this is really imperfect data because there's a lot of things, again, as I'm sure you all know, that we're not always clear about sort of how we're counting these things. And so are we counting people who have one interaction with the mental health system? Are we counting people who actually get into treatment that's effective for them? Sort of who and what we count, I think, is very imperfect at this moment in time. But this is sort of what we have and what we can look at. And so what we see in the data is that there are differences or disparities. And if we can go to the next slide. So in particular, and so that just to say, disparity can be sort of both under service and underutilization, but also over, because that can tell us things too, right? So here we see, we look specifically at the Black population because we know that we have real challenges in getting appropriate mental health services in that community. So what we see is a very, very low utilization of the health plan mental health services, right, which is a lot of the earlier intervention, the mild to moderate type of services, and very high utilization, actually higher than we would expect based on share of the population, utilization of the county mental health or the specialty mental health services. And so this makes us think a couple things. This makes us think, one, that, that Black communities lack access to the earlier intervention and the more mild to moderate services that are going to be particularly important, and that perhaps people are having to wait until they have a much higher level of need to get into services, which is not equitable, right? It also makes us think that perhaps there are inappropriate referrals happening. And so one thing that we know from the literature is that providers, and sometimes when people are doing assessments, will make judgments about the type of mental health needs that people have based on race. And in particular, there's sort of a trend to diagnose people who are Black with mental health conditions that are perceived as less treatable. And so that might be part of what we're seeing here in the data, and that's sort of inaccurate diagnoses, inappropriate referrals, sort of not actually being responsive to the needs of the individual or the community, but really putting our own biases on people. If we can go to the next slide. So we also looked at by language, and this is fairly new data that's now available from the Department of Healthcare Services, and that you really see disparities in terms of who is served. And this is all showing penetration rate, right? So it really shouldn't be different by language, but you can see it is strikingly different. And particularly when we look at people who speak Spanish, a dominant language in our state, right? Cantonese, Vietnamese, there are more languages, but these are the ones that there's the most data on that we pulled. You can see clear disparities, people not getting access to mental health services from either system, right? So people just broadly not getting access to mental health services. And so it's something we want to pay attention to when we think about how do we design our services, do we do outreach? How do we make sure that people have the access that they need? If we can go to the next slide. So this is actually the data that concerns me the most when I think about racial disparities. So what this is showing you is we sort of clumped together all of the non-English languages. That's the red line, and then English is the blue line, right? So you see the disparity there. This is over time from 2013 to 2017. So if you look at the gap between the red line and the blue line, it's not getting smaller. In fact, it's getting a little larger, but it's more or less the same. And I think that, you know, we really like to think we're making progress in this state. We're getting people better access to care. And what this shows us is, at least using this data point, we're not closing disparities. All the different things we've done, we are not ultimately closing disparities. Now, that doesn't mean there isn't really good work and progress happening in specific places. And I think even, you know, a huge shout out to the NAMI programs, right, that I think do a lot of this work. But broadly across the board, the state is not closing these disparities. And so, you know, that is alarming to me, right? And I think speaks to the need to really sort of revolutionize how we're thinking about health equity. So if we can go to the next slide, please. So I talked a little bit about this, and again, want to emphasize, you know, the disparities are not based on race, they're based on racism, which is structural and systemic. And the response also needs to be structural and systemic. And so I'll talk about a couple of the things that we're working on in terms of response and solutions. But just to say, you know, kind of summarize that there are disparities. They are both in mental health and in health broadly. And because we know that people living with serious mental illness often have untreated or poorly treated chronic health conditions as well, it's really important to look at the totality of that picture in order to start to break down these things, and that some of the contributing factors that are part of structural racism have to do with exposure to stress and trauma, lack of access, particularly early and prevention type access. I bolded underdiagnosis and misdiagnosis because I don't think we talk about that enough, right? I think sometimes we have a perception that if people can just get access to care, we'll sort of solve this problem. And our experience is that actually there's a lot of problems even within the care itself, right? Which is the other sort of bolded section here, which is about the poor quality of care and treatment. And what do I mean by poor quality? I mean that the care or the treatment is not right for the person who's receiving it, and it's not working for them, right? And this is a difficult one to look at with data because one of the big gaps, again, I'm sure you all know this, in our system is that we don't do a lot of outcomes, right? We don't report on outcomes in any robust manner. We haven't agreed on what the outcomes should be. So it's really hard for us to look at this in terms of data, but we know this from our experiences and from our community experiences. And we even know things like, there was a study that showed that Latinos who maybe go to therapy once are very unlikely to return to therapy, right? Even if it was going to be an ongoing type of treatment. And so that tells us there's something happening there when receiving the treatment that is not working for that community that we really need to pay attention to. Next slide, please. So there's a lot of conversation about behavioral health reform. You all know this. You're at the forefront of it, right? And we believe that we must approach behavioral health reform through a racial justice lens. That equity and racial justice cannot be one component or sort of one way to look at behavioral health reform, but it has to be the lens through which we focus all of our efforts. Otherwise, we will perpetuate and even worsen the disparities that we see today. Next slide, please. So a few of the things that we're thinking about in terms of reforms or solutions or whatever term you would like to use. So I think one big concept is that data does matter because what we measure, what we report tends to be what gets done, right, in a system that's sort of driven that way. And so one of the things that we believe is that new evidence needs to be built. And so that's both the data work that we do and getting the state to look at their data with a racial equity lens, but it's also thinking about how do we demonstrate what works, and how do we build what works, and how do we build new things that work, or build the evidence for things we've been doing, communities have been doing for a long time, that maybe we're not able to sort of communicate why they work using sort of the same standards or those kinds of things. And so the integration of community-defined best practices, which are essentially mental health practices that communities have come up with and even historically had for generations, those kinds of things, but are not well integrated into our system, even though we know they tend to work and they tend to work better. So building the evidence for those programs and incorporating them into our mental health system is one kind of pillar of our work on mental health equity. And the other piece, I think we cannot ignore COVID and the impact that COVID has had in so many ways, but particular to mental health, the increased need for mental health services, even just for sort of basic connection with other people to keep us all well and resilient. And one of the sort of on the positive side, one of the things that I think COVID has demonstrated is that we can change our delivery system. We can do it quickly when we have to. We can make pretty dramatic reforms when the need and the will is there. And you see that in COVID with our quick shift to being able to do everything online, even, you know, this presentation, right? So we know we can do it. I think that's a really important lesson to take from COVID. One thing in particular is the use of telehealth and telemedicine, which has been something that I think in our health delivery system we've sort of struggled with. How far can we go with it and those different things? But I think more and more we see it's working well for folks. In many cases, it's not perfect. There's a lot of things that can't be done over telemedicine, but we just put out a big survey to the field, particularly to communities of color, asked people, what's your experience? Did you see a doctor or a mental health clinician via your phone or video during the pandemic? And we're still analyzing the data, but I think the big picture is that a lot of people prefer telehealth, and specific to mental health, it does seem to be working well in many cases, and particularly for communities that lacked access. One thing we've heard from our Native American partners is that at some of the community health centers, particularly some of the Native American community health centers, the rates of people showing up for their mental health appointments is dramatically higher when we're able to use telehealth. And so we really want to take some of those things into consideration. We want to make sure that the changes we're working are going to work for communities of color, but we really want to dig in and adapt where we're seeing new and different things working for communities of color. Next slide, please. So I said data matters, money matters too. I think we all know that from our personal and household budgets, right? Money matters, you can't ignore it. And we are up against tough times in our state, right? Due to COVID. We have a $54 billion state budget deficit, which is going to impact every part of our state government and the programs that we deliver. I think we feel very strongly that the road to recovery means actually investing more deeply in the people and the care that has been most impacted by the pandemic, so investing more and not less. But you still have to fill that gap, right? And so some of our advocacy has been around, first with this most recent state budget, really working to sort of stave off some of the proposed cuts to public health care, mental health, social services type programs, which we as a community were successful in doing that for the most part, but we know that this is going to continue to be an issue and that there's basically three places to look, right, to fill this gap. And so this is a big part of our advocacy, is making sure we have the dollars to provide the mental health care that we know our communities need. So just really briefly, and I think this is also for folks to know that these are places you can plug in terms of advocacy. If you're concerned about your county mental health budget, which I think we probably all are, there's sort of three big places to look, right, to fill in that. One is the federal government and the CARES Act and the federal stimulus money, which, you know, a lot of it is held up now. But we at CPEHN are very active in lobbying Congress to sort of get its act together and get the dollars to states and counties where they're needed. So happy to plug you all into that advocacy if you'd like to be involved. The second place is new revenue. There's different ways states can raise money, right? Whether it's through taxes, different things. And and that this is an important time to look at that given how deep the deficit is projected to be. And the third piece that I think might be most interesting in this group is county budget priorities, because there's a lot of money that counties have discretion over that doesn't currently go to mental health, and it might go to other types of programs, and sort of law enforcement being the biggest piece of the pie. And that now is a good time for all of us who are active at the local level to be talking to our counties and to be saying, we need to really look at this whole picture because we have really significant mental health needs in our county that we will not be able to meet unless we change the picture of our county budget. We have a tool coming out shortly that will allow you to look at your specific county and how the county budget breaks down and what percentage of that is mental health, in addition to what percentage of that is public health, because we've all learned through a pandemic we don't invest enough in public health, right? And if we had more testing and all of that, we might be in a better position. So it's a tool for advocates to be able to use to look at the decisions your county has made, and then be able to utilize that tool in your advocacy for potentially different budget priorities in your county. Next slide, please. And then sort of the third piece of this is a bigger, broader campaign around saying that we know that disparities exist and we know that racism is at the heart. And it has come, I think, to a point in our state and in our country where we really need to acknowledge that racism is a public health crisis. There's no other way to think about it. And that the only way we're going to really make a difference in some of the issues I talked about is if we are able to acknowledge this and if we are able to take really significant steps in how our institutions are shaped, to our state government, our county governments, our hospitals, our health systems, and the racism that is baked into those systems, right? It's not about a person with bad intent, it's about systems, and that they are actually operating the way they were designed to operate, and that we need to change how they are designed. And so we, along with many, many, many organizations across the state of California, including NAMI California, have called on the governor to declare racism to be a statewide public health crisis, and to take action steps accordingly to start to dismantle racism within government. And so, you know, we welcome your participation in that campaign as well. It's on our website. We are continuing to sort of build up the pressure to get the governor to make such a declaration, as well as to get our local government institutions to really look at how they do business and how they can, I think, more robustly embed equity into their work. So I think if you go to the next slide, so some examples, because people have kind of said, oh, that's it. What do you want? Do you just want the governor to say this? Like, what do you really want? So this is, you know, with some input from different folks, some various different things that we really think governments are responsible for thinking about when we think about anti-racism work. And so just to highlight a few, I think starting with fundamentally acknowledging the effects of racism and particularly I think the pernicious effects of anti-Black racism, looking at our internal government policies and procedures with an equity lens, thinking about laws and regulations that need to change, looking at our workforce and how we do hiring and contracting and who are we hiring and who are we contracting in a way that better invests in communities and allows communities to build those resources as well. Having adequate resources for anti-racism activities, building partnerships. I think this one is really important too. Building partnerships with organizations that are at the forefront of confronting racism and that are deeply embedded in communities. And sort of generally, I think, authentically engaging with people of color. And I think, you know, some of these are places that I think NAMI's had a lot to say in terms of how do you engage with stakeholders? How do you engage with family members and consumers? And I think adding that racial justice lens to this, I think, is very powerful. Next slide. I think that might be my last slide. Yep, that's my last slide. So I'm happy to take questions, have a discussion. You know, I think I'll just say, again, for us, this year has, I think, really demonstrated that there's it is imperative that all of us really focus explicitly on racism, and that until we do that and really move forward with that, we're not going to be able to make progress on disparities. And I think the sort of bright spot to me is the extent to which organizations and institutions and people are focusing on inequities and racism in a way that I don't know that was seen before, right? And so I think that's very hopeful. And I think that, you know, we can make a lot of change together. And so I'm happy to engage in a conversation, or however Angela wants to facilitate this.
There we are. That was weird. Sorry, technical difficulties. It's the new part of our job, is internet connection, and is my mic on, and can you hear me, and all that good stuff. So thank you. That was incredible. We got such great feedback. I think that these conversations have always been important, but I think right now there's a really opportune time to get them at the forefront and maintain that momentum. So the work that you're all doing and the information and the data that you're collecting, you know, is, like I said, it's always so important to have that information and have those conversations. But, you know, now more than I think, at least in the time I've been doing this work, there's more space created for the conversations, and there's more people in a position to make change and make decisions and put that where it needs to be. So thank you so much for your leadership and all the work that you're doing, you know, in those spaces. So now we have some time for anyone who's got questions. If you want to go ahead, you can enter your questions into the chat box. And again, we just kind of want to remind everyone, you know, for our community agreement to, you know, use this space respectfully in an inclusive way to create safety and comfort for those that are bringing a different perspective or maybe want to ask questions. I know that the adage of, you know, if you have a question, it's likely someone else in the room has the same question. So even though we're all in separate rooms, I think that, you know, that still holds here. So I'm going to open that up. There we go. So yeah, if anyone has any questions, we can go ahead and do it that way. And then also for those, just as a reminder, we are recording this. We'll send out the materials. So the slide deck that Kieran presented today and a link to this recording will be available for all of you. So if there's information on the slides that you were looking for, and then I know that our team, and as a side note, thank you so much to our team for all of the support on the back end, monitoring the chat box and helping out when I had to switch devices because my Wi-Fi is terrible today. So thank you for that. And then, you know, also just a huge thanks to Jessica, our CEO. I think when we started talking about how we could have these events, you know, what they would look like, it's really just, it's taken off, and we've been able to have a lot of really wonderful conversations with folks working at the state level, kind of tasked with that oversight of the mental health system. And now with Kieran and some of our other partners coming in over the next couple of weeks, we'll actually be able to connect with those that, you know, like our folks within the NAMI family, are working really hard at the community level to, you know, help families and individuals. And so I'm excited for the conversations that are to come, but really excited for the work that's been done through these events. And so just hats off to our leadership for that idea, because I think I know that we've gotten a lot of great feedback from folks that connecting through these meetings to the state agencies and entities have really helped sort of demystify the mental health system and, you know, kind of who's doing what and where. So thank you for that. I don't have any questions coming up yet in the chat. I don't think. Sorry again, I'm like, what's happening with my computer today?
Angela, there are a couple of questions that I think only got sent to me about data and more granular data. So I'll just say, I mentioned a couple of things we're working on. I don't know that I have any of that data at my fingertips, but two things that will be on our website by like end of the year. One is the county by county spending or budget data. So if you just bookmark our website and check back in a few months, that should be available to you. And then the other piece is, I think, trying to make some of this data that I presented from DHCS a little bit more available or accessible to folks, because it's, if any of you go to the state websites, it's really hard to use and to find it. And so someone's asking for like the race data also cross-tabbed by age, which I think is really important. You will be able to, we're going to have a function on our website towards the end of the year where you can kind of put in your own variables and come up with that kind of thing and create your own sort of county analysis. So again, I'm sorry I don't have it today, but if you check back in a few months, it should be fairly available to you on our website.
That's really exciting. And we'll definitely, as that becomes more readily available and as you guys work on that, we can definitely pass that along and share with our folks too. I think really for those working locally, having that information, you know, whether it's demographics or the money that's being spent, I know that there's a lot of efforts right now underway to paint a better picture of what's happening in communities. And so I think that'll be a really exciting piece of that puzzle. So we'll definitely share that and keep folks informed as that moves along.
And I have a quick question, Karen. So that information that you get, all that data that you're collecting from DHCS, is there anything that differentiates it between like a family member and a consumer, or is it just like individual living with a mental health condition that are responding to this? Yeah, so that's what we, as you know, for many, many years, we've always been struggling on how do we collect our data as family members and as individuals to share the same story of like, look at this, you know, the need there. So that would be something interesting, I think, for us all to think about as we advocate, is how do we also figure out how do we tell our story as family members and individuals in the same way that we can tell this, you know, disparity story to show the individual and the family perspective here. I was curious if you knew of anywhere that collects that information.
I do not. I think it's a great point, because a lot of it is like you know, it's like billing, right? It's like who used the service and sort of reporting on it. It's not giving us that bigger picture. So I don't know of anything. The only thing I will say, I mentioned this is a very specific issue. I mentioned we just did a big survey on telehealth, and we should have the data coming out soon. We did ask people, you know, to reply to that. It was for a broad range of healthcare, but we are going to be able to separate out people who utilize telehealth for mental health specifically. And we did ask people to respond for themselves or for a loved one or a child. And so if we have enough data, we might be able to pull it on telehealth experience specifically. And we haven't gotten deep enough to know kind of how many people did respond as a family member, but hopefully we can at least share that if we have it.
I'm so glad you added that to the question, because as we all know in doing this work for so long, is that a lot of times, I mean, in various different communities, families are a huge part of accessing the treatment and or even, you know, making sure that they have that continuum of care and that they're, you know, have compliance and things like that. So it'd be interesting to see from even just a telemedicine standpoint, how involved families were in answering just the survey even.
Yeah.
Hey, Karen, Steve from NAMI, California, quick question. A lot of our folks listening today might be thinking like, oh, you know, I didn't know this information. I'm so, you know, I want to help here. Can you give us some ideas of some good first steps that maybe folks could take at a local level to kind of support this work or think about starting the conversation locally if it's not happening?
Yeah, so great question, Stephen. So I think a couple things. I think one of our big values is that people need to be connected to each other and be able to work together. So I am happy to make any introductions or connections between NAMI affiliates or other stakeholders and the folks that we work with. I think there's much stronger advocacy potential together, right? So I think that's one thing that we can certainly do. I think, well, I'm going to put in my small plug for, you know, local decisions are mostly driven by people we elect. And so one of the biggest things you can do right now is September of 2020, make sure you're registered to vote. If you're eligible to vote, make sure you're registered to vote. Make sure you double check you're registered, make sure you mail back your ballot, all of those things, because you know, when we talk about the county spending decisions, we're talking about people we vote for, right? And so it's really important for people to do that. So that's probably the number one thing I would say in September 2020 for people to do, but get connected with other people. And then I think the third piece is really participate. I think sometimes we discount whether or not our voice matters, right, in state and local decision making, and it does. It always does. And so, you know, participate. Go to your boards of supervisors, see what they're talking about. Add your voice to that conversation. And same thing at the state level. I think one of the sort of small benefits that's come out of COVID is everything is virtual. So a lot of times you don't have to go to City Hall now to participate. You could just get on the phone from the comfort of your pajamas, right? And so I think really sort of it's a time to step up our participation too, right? Because I think there's just so many challenges, and I think for us to get the solutions that are going to work, we're all going to need to participate.
Totally agree. And I think one of the things I've always really appreciated about your approach, both at NAMI, ACLU, and now at CPEHN, is really thinking about these structural pieces, right? Like we're even talking about this, like how is the data itself collected? And so I think like, I really love this idea of thinking about like, how are you thinking about your local structures and how are they kind of keeping in place racist systems or things that are just not serving communities equitably, and how can we then have an effect on those systems? In the same way that we think about family care, we should also be thinking about, you know, equitable justice for care across communities within our local areas too.
Mm-hmm. Yeah, yeah. And I guess the one thing I would add actually to the things I talked about that we've been thinking about more and more at CPEHN is like, if we think about systemic racism, we have to look internally too, right? We have to look at our own institutions. And, you know, we are a health equity organization and we have to look at ourselves, right? I have to look at how are we, you know, choosing who to hire, which vendors to contract with, all those things, all of those have a component of how we can improve equity. So I think even in our local NAMI affiliates or other organizations, this is a really important time to sort of dig deep and personal too, and do that internal work as well.
Love that, love that.
No, I think that's a great point, and I'm excited because for those of you who don't know, NAMI California and now CPEHN also hold contracts with the Mental Health Services Oversight and Accountability Commission as part of their stakeholder advocacy funding. And so we'll be working in partnership with them over the next couple of years to do local and some state advocacy work. And so these conversations that we're having today, you know, will continue through that partnership, and we'll work with, I think it's 7 total organizations to build the capacity of communities from a local advocacy standpoint, but also bring those issues and conversations up to the state level. And so, you know, I think it's really exciting because as we all sort of examine, you know, our internal systems and processes and, you know, our own internal biases, either as an organization or as individuals, you know, there's really great support within all of our different organizations to do that together and to think about how we can, you know, advance that conversation, not just right now in the next couple of weeks, but, you know, over the next months and years, and really push forward to create that change. So that's a really exciting, you know, piece, is that we look forward to working more with CPEHN on this as one of the contract holders. I did have a question that popped up. One of our participants wanted to know, how engaged are the various communities in voting for mental health bills? So I don't know, that's kind of a broad question, and it would be, you know, looking at data from, you know, across all, but if you have a sense of, you know, whether or not there's an answer to that. Oh, wait, here we go. So state advocacy, oh, I think that was a separate conversation. It was the same person, but so yeah, for the voting.
So I'm not completely sure if I understand the question, but I can answer it how I maybe interpret it, which is about the just maybe level of engagement in the policymaking process in communities of color. And so I think that that has been one of the challenges, right, with all of the systemic barriers, is that who gets heard, right? Who gets heard in Sacramento? Who gets heard in our counties in terms of decision making? And I think it's similarly, as Jessica might point out, a challenge for family members, right? So I think we have some synergy and alignment around that. I think one of the things why we have sort of the model we do, is that we believe that because there are these challenges, it's really important for us to sort of stick together and have this bigger unified voice, that sort of if each of us is advocating fully on behalf of our communities. That's really important. We need to do that, right? We need to tell our stories and do that. And if we're able to support each other in this work, that our voice will be so much bigger and so much stronger. And so, we think about that from a sort of multicultural perspective, but I think there's a lot of ways to think about that. And I think Angela's points around the sort of parallel projects we all have going on now is an important place to think about that. Like, how powerful would it be if it wasn't, just family members or just whoever going to the Board of Supervisors and saying, hey, we need this change. But if it was, diverse racial communities, if it was LGBT communities and family members all going together and saying, hey, we've come with this strategy, we all think we need to see this change, that could be such a powerful voice.
Absolutely. Well, and I think what we've said for a long time is that there's such deep intersection between all of those. I mean, a lot of folks check more than just one box. If you're a family member, there's also family members that are part of the LGBTQ community and are from a racial, or ethnic community that are also veterans, that are not just someone themselves living with a mental health issue, but maybe raising a child, or they're the child of so there's so many intersectional identities. And I agree. I think when we go in together, the message is unified and it's more powerful, and we can do a lot more together than we do on our own. And I think, to the point in the chat box, Lana's comments, like we do need to get excited about the local work, because as you said, Karen, that's where the decisions are being made. Even at the state, a lot of entities will tell you, sure, we have, opportunity for stakeholder engagement, but if you really want to, get in and have that conversation, you've got to do it locally. And so the goal for this project, or the goal for this next round of funding from the OAC, will be to get in and help strengthen that local level presence and bring those conversations to where they need to be. So I think it's really exciting, and there's a lot of work to be done, but we have, I think, across the contracts, there's a lot of really strong partnerships. And so I'm excited for what we'll be able to do with that. So let's see, I don't have any other questions that are coming in through here. So if anyone has any other questions, you can go ahead and enter them into the chat box. Any thoughts or comments? I know that we've shared a lot of information. Our teams put the links to the different things into the chat box. So I'll make sure all of those are also included in our follow-up materials. Let's see, I don't have anything here. So I think if there's any final thoughts or things that you wanted to share with the group, Karen, or if there's anything you wanted to add, Jess, I don't have anything coming up here in the chat box, so we're good on that end. I think we have on our next slide, though, just some information about some upcoming stuff we have here at NAMI. Let's go to the next slide. So we have our link to our evaluation today. We always like to hear kind of how we did, any thoughts that folks have that are participating. And then our next town hall will be with the California Alliance of Child and Family Services, and that'll be on September 29th. And that registration link will pop into the chat box also. And then we're working on securing dates with the California local mental health boards and commissions and a few of our other community partners. We've got some plans for discussions on student mental health and helping parents support their children, not just during COVID, but in the space of distance learning, and really addressing and discussing some of the challenges that families are facing as the school year has kicked off from living rooms and bedrooms across the state. So we'll work on that and bring that information to you. And then do we have the conference information on the next slide? Yes. So our annual conference is taking place virtually this year. It's free registration for folks. The link is here on the slide. If you haven't registered yet, go ahead and follow that link. You can register. It'll be on October 12th and 13th. We've got a really robust slate of presentations and conversations, and so you can register there and get into the platform and kind of check out what we've got coming up. And I think that's the last of the updates there. Yes, so if you have any further questions, if there's anything that you think about that was presented today, or anything that Kieran covered that you want more information about, go ahead, you can reach me. My contact information is here on the slide, angela@namica.org. I can get you in touch with Kieran. I know that Kieran's contact information was also shared in the chat box, but we're always happy to collect any final thoughts or questions and get you the answers that you're looking for. And our team is putting that in the chat box now. So I think that's it. That's the last slide. I just really want to thank everyone for being with us today. There's so much going on right now. School year starting, all of the fires that are happening around the state. I hope that for everyone here and for those that you're connected to, I hope that everyone is safe and healthy. It's a really scary time right now to be in California. And so just I wish everyone health and wellness, and thank you all for being here today, and we'll see you at the next event.
Thank you.
Thank you.